Welcome to the LACNETS podcast. I'm your host, Lisa Yen. I'm the LACNETS Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. Welcome to today's episode of the LACNETS podcast. I'm really excited to introduce today's guests, Dr. Will Chen and Dr. Alexandra Hotca, both from University of California, San Francisco. And I met them recently at the NorCal CarSNet Patient Education Conference in September and heard them speak and explain these concepts to the NET patient community and felt like we had to have them here as they treat cancer patients, including neuroendocrine cancers. And this is a topic that has come up, but I honestly don't know a lot about. And I know a lot of patients, it may come up whether it's their own cancer or someone else that they know of, and they might have heard of radiation oncology or different means of treating with radiation. And so I thought it would be wonderful to have them here today. So Dr. Chen received his undergraduate degree from Johns Hopkins and completed his medical school at University of California, San Francisco, completed his internal medicine preliminary year at Kaiser San Francisco, followed by a residency in radiation oncology at UCSF, and also participates in research developing biomarkers in informatics and clinical trial development. And Dr. Alexandra Hotca specializes in treating gastrointestinal cancers with an expertise in advanced radiation therapy techniques, such as intensity modulated radiation therapy, image-guided radiation therapy, and stereotactic body radiation therapy, and respiratory gating. These approaches are all designed to optimize treatment outcomes, minimize side effects, and her research really focuses on enhancing patient quality of life through preventative strategies and identifying predictive biomarkers for radiation-induced toxicities, all of which sound very interesting to us in the community. And I know both of you are very dedicated to exceptional care for the diverse patient community at UCSF and nationally and globally. So thank you for all you do. Thank you for speaking and participating with the NET patient community. A couple fun facts. Dr. Chen plays banjo. I guess that's from his Midwest upbringing. And Dr. Hotca enjoys running marathons around the world. And she's already ran 9 so far, mostly in Europe, which is really cool to run around the various cities and tour those cities in that way. So Dr. Chen and Dr. Hotca, welcome to the LACNETS podcast. And if you might explain to our audience, what got you interested in this field of radiation oncology and into this field of neuroendocrine cancer?
Sure. Yeah. Maybe I can start. First of all, thank you for having us. Really excited to be here. Really excited to help get the word out about our field, which is a relatively small one. Well, about myself, I actually come from an engineering background. I studied engineering as an undergraduate. So I always knew whatever field I went into in medicine, I want to have kind of a strong technological focus. And as I went through medical school, I eventually was connected to a mentor who was a radiation oncologist and started doing research in the field and just found myself drawn to how much technology and imaging is involved in radiation oncology and also the big difference that we can make in cancer patients' lives. So that's what really drew me to the field as a whole. And then for neuroendocrine tumor, I think it's a function of being at UCSF. As a medical student, had minimal exposure to neuroendocrine tumors. And then as a resident, maybe a little bit more so. But I think it's really a unique place at UCSF because we have Dr. Bergsland and Dr. Tom Hope and everybody else that's part of the neuroendocrine program. And they've really created this amazing multidisciplinary tumor board and program. And as I got more exposed to that and eventually became involved in tumor board as well as part of my role as a clinical instructor here for the past year and a half, I've just really found it to be an amazing community and amazing program.
Wow. And I know that from talking to you in San Francisco that you see quite a number of neuroendocrine cancer patients. This is regular for you. And so you're very familiar during your time at UCSF with neuroendocrine cancer. Well, thank you so much. And Dr. Hotca, what about you?
Sure. Thank you, Lisa. Thank you so much for the wonderful introductions. And it's really a pleasure to be here today. Like Will mentioned, we are a small field, so we're very excited to hopefully shine a little light in our field and how we can help our patients with neuroendocrine tumors. And regarding my background, I started getting interested in the field of oncology before I even entered medical school. One of my family members had cancer themselves. So I knew then that I really wanted to focus in this field. And then during medical school, I got the opportunity to do some research as Memorial Sloan Kettering with a wonderful mentor in radiation oncology, actually. And that's what drew me towards this field versus going into medical oncology or the other oncology specialties. I just really enjoy working with this person. So I think that's what drew me especially to this field. And I also realized that in radiation oncology, we do have more time to spend with patients. So I did like that I'm able to actually sit down with my patients and not worry about timing, which to me is very important. In terms of exposure to neuroendocrine tumors, similar to Will, is really just being part of UCSF. I actually recently joined UCSF, so I'm very excited from learning more about neuroendocrine tumors because this is a very special place. There's not that many places like this in the country. And just by attending bi-weekly basis, those tumor boards with Dr. Bergsman and Dr. Hope, it's just very remarkable. And I'm still learning a lot. I'm very excited to be part of this community now.
How wonderful. And the community is fortunate to have you as part of the community as well. So it's amazing. People influence us, right? The importance of mentorship, connections, networking, and how that can really make an impact. And it sounds like you both have such passion for this field, and we like to see passion. So this might be the perfect segue into, if I could ask you the first question, what is radiation oncology and what is it all about? Dr. Chen, I guess we'll start with you.
So radiation oncology is a field in medicine where oncologists specialize in using radiation to treat a variety of cancer types and tumor types. And 35 years ago, we were part of radiology, but we eventually branched off into an independent field. So we go through independent residency training separate from radiology for 4 years. And the vast majority of what we do is called external beam radiation therapy, meaning the radiation is delivered using machines where X-rays come from the outside in, and all these X-ray beams intersect at the region where we're trying to target. And we have a variety of amazing technology and imaging tools that we use that help guide the radiation to be very precise as possible, to target the tumor and to spare all the normal tissues around it. So some of the advantages of doing this external approach, external beam radiation, is that most of the time it can be a very non-invasive treatment. A lot of the time it's very similar to getting a scan. So patients will be lying down on the table and there's a big machine that moves around them. And as the machine moves, it's delivering these X-ray beams. So just like getting a CT scan, these X-rays are just passing through the body. And so you're not radioactive afterwards. You don't have to worry about lingering radiation in the body. And like I mentioned, the vast majority of the time, it's a non-invasive and painless treatment to receive.
Yeah, thanks for clarifying. It's very confusing because radiation is in so many words, right? And it's similar to radiology. So really distinguishing how this field is different from radiology. Dr. Hotca, I was wondering if you have anything to add to that and what is it that you do and how is it different from other types of radiation?
I think Will explained it very well. As you mentioned, we branched out from radiology. Fun fact, we often called radiologists still, not to date. So that is a common way that patients or even other specialties address us. No, I don't think I have anything else to add. Dr. Chen really explained it well.
So radiation oncologists and radiologists are not the same thing. So Dr. Hotca, maybe we'll ask you this next question. What are the types of radiation therapies then that can be used for neuroendocrine cancers?
Sure. So often for neuroendocrine tumors, patients may receive either internal radiation or external radiation. So today, for the purpose of the topic, we will focus on external radiation therapy, but I just briefly want to explain the differences. So often internal radiation therapy for NETs typically involves radioactive material, which often is called a radioisotope that travels through the body and allows cancer cells to take up the radioactivity directly, ultimately destroying them. And one such type of treatment that we are familiar with is called peptide receptor radionuclide therapy, or PRRT. So that is one type of radiation that is internal, is administered through IV. Actually, often it's not administered by radiation oncologists. Depends on institutions, but typically is administered by other specialties. And then the radiation that we administer as radiation oncologists more often is the external type of radiation that Dr. Chen mentioned earlier. And in external radiation, as he mentioned, it's really delivered from outside the body. So there's no invasiveness to this procedure. We can visualize the tumor through tools such as X-rays, CT scans, things like that. So we use imaging to our advantage to visualize what we want to treat. And then within this category of external radiation, we actually have a more specific type of radiation called stereotactic body radiation therapy that we nowadays use more and more frequently as we got better with our technologies to be more precise. And this type of radiation allows us to deliver a much higher dose of radiation to a well-defined area without radiating surrounding normal tissues. So SBRT uses advanced imaging to deliver a very concentrated high dose of radiation to the tumor specifically and to minimize the impact on the healthy tissues. However, I do want to mention that while this is a great technology that we have and we're so happy to offer it to our patients, it is not always feasible to offer this type of precise radiation, which is usually often delivered up to 5 treatments total. If we think that it's too high of a dose to safely be delivered, then we have to break down the treatment into more sessions. And the sessions in radiation, we have to call them fractions. So instead of using 5 fractions, we will use more fractions just to give a slightly lower dose of radiation to be safe for the patient and for the surrounding tissues. And in that scenario, we often call it a hypofractionated approach, often using about 10 to 15 treatments to deliver the radiation instead of the SBRT type where we use up to 5 treatments.
Wow, thank you for explaining that. I'm glad that you clarified because, again, radiation is commonplace in the neuroendocrine cancer field. You're thinking of radiation exposure with maybe the imaging and then TRT, which is common now. And this distinguishes it with this external type of radiation with SBRT. So, Dr. Chen, which type of neuroendocrine tumors can radiation therapies be used for, and when are they used? And how do you decide who's a good candidate for it?
Great question. So neuroendocrine cancer is a very diverse group of cancers and tumors, can really arise in all different types of places, as we know. And I think one of the big things that came out of the patient conference that we all attended recently was that really there's no one size fits all. If there was one liner from that conference, it was there's no one size fits all. And really recommendations have to come down to discussion between all the different disciplines. So medical oncology and surgical oncology and radiology, and us in radiation oncology discussing cases at tumor board and coming up with the best plan for a given patient, especially taking into account patient desires and wishes and of their background. So I would say that radiation can be delivered technically to almost anywhere in the body. And so the question really comes down to not if radiation can be given, but whether radiation should be given for a particular patient and case. And that comes down to, like I said, the discussion and things that we consider when we make these decisions is what is the pace of disease, for example? How many different sites of disease are there? If there's many different locations where there's tumors seen on a DOTA-tape PET, for example, that may be a more systemic issue where something like a systemic treatment with medical oncology might make the most sense first, or something like PRRT, which can travel all over the body to treat tumors in all different locations. So radiation oncology is maybe a little bit more akin to surgical oncology, where we are applying radiation to a local area or to a particular spot that we can see on imaging and trying to deliver a high dose of radiation to that area to stop that tumor from growing. And so it's thought of as a local or a local regional therapy. So in certain situations, that might make sense. For example, if there's just 1 or 2 spots and maybe the surgeons can take care of one spot, there's another spot that the surgeons can't reach, or radiation can reach, that might be a good rationale for applying radiation. Or another category of radiation treatments is something called palliative treatments or palliative intent treatments. So that would be in the case if there's a tumor that's causing symptoms, pain, obstruction, or bleeding, or something like that. Radiation can be applied usually to a lower dose than we would do if we were trying to deliver a high degree of local control, but to try to alleviate some of this. So those are some examples of situations where radiation might make sense.
Thanks for that thorough overview of that. And you mentioned it can be used pretty much anywhere in the body. Are there specific places for neuroendocrine cancers that it might be used, like the bone, liver, pancreas, rectum? Are there specific organs that they're typically used?
For our practice, what we see the most frequently is liver tumors. We can go after those with SBRT. There's other forms of liver-directed therapy too, but we're one of the various options. We sometimes have a role for pancreatic tumors as well. In the non-neuroendocrine realm, we also treat pancreatic cancer patients. So it's a very similar kind of approach in anatomy. And so if there's a reason that some local control is needed for a pancreatic neuroendocrine tumor, SBRT can be offered. And then I'd say for things like rectal neuroendocrine carcinomas, the more aggressive neuroendocrine cancers, sometimes there's a role for chemoradiation, which is the addition of chemo together with radiation to work together to try to deliver control to at least the rectal and pelvic area. And usually after some chemotherapy has been administered, there's been evidence of a response, and then we would like to consolidate, try to make sure that the control of the tumor in the rectum and the pelvis is as good as possible. Sometimes they'll be followed with chemoradiation to try to take care of the disease in that region.
So in combination to attack it again from a multidisciplinary approach. Dr. Hotca, where in the body can SBRT not be used?
That is a great question. So, like Dr. Chen mentioned, we can use it pretty much in every part of the body, but there are situations where, unfortunately, we cannot offer SBRT. And those instances are often, because we do see a lot frequently liver lesions or pancreatic lesions, those are often surrounded by small bowel, large bowel, stomach. So we do know that bowel in general is very sensitive to radiation. And any hollow organ, we are always more careful to deliver a high dose of radiation when we are nearby such an organ, because then we can cause a perforation and that can lead to many issues down the road. So often if there is a tumor that is right next to the bowel, that may be something that we may pause for a second and either use tools or techniques that we have available. Respiratory breath hold, where we ask the patient to hold their breath so that we minimize the movement in the body so we can be as precise as possible. Or in other times, we just use more fractions of treatment. We deliver a smaller dose every day and just more treatments to be more cautious. So in that case, we would not use SBRT. Other times that we would not use SBRT or radiation in general is when patient had received radiation before, external radiation, not PRT, not other interventions, but external radiation. We are extremely careful when we talk about re-radiation in a specific area because that tissue has seen radiation already, and that means that tissue is now more sensitive and it will develop more side effects from the radiation. In that scenario, we take it case by case. We now do more and more re-radiation. However, we have to be extremely careful. So that is another instance where we pause for a second before we consider delivering radiation. So those would be the two main areas. And of course, if there's other organs, such as in the brain, if there's some tumor that is very close to the optic apparatus, something like that, also, we may not be able to offer such a high dose of radiation because we are worried it may cause damage to the nearby organs.
Okay, so taking into account what's nearby and then exposure to prior external radiation. So, Dr. Chen, you said that a lot of times you're treating people with liver tumors with external beam radiation. Is there a certain limit or size of tumors? How do you go about figuring out which people are the candidates? I know, like ablations, for example, there's a certain size limit. So, is this true too with SBRT?
It's also true to some extent with SBRT. I think a little bit to a lesser degree than for example, for microwave ablation, where the heat has to travel a certain distance so that if it's too large, the heat can't get to the edges of the tumor. And with radiation, we're coming from the outside in, so we can treat larger lesions. But usually what we try to take into account is how much of the healthy liver we can spare from radiation to make sure that the patient has adequate remaining liver function. The amazing thing about the liver is that we have usually a lot of healthy liver to help us take care of our daily needs. And so our typical cutoff is like 700 cc's of healthy liver, similar to the surgeons, to keep under a threshold dose of radiation to make sure that there's adequate residual function. Aside from that, we also take into account nearby structures. So as Dr. Hotca was mentioning, sometimes if the tumor is towards the edge of the liver and there's bowel nearby, that's another limiting factor as to how much radiation we can deliver. But taking those two things into account, and there's not a hard and fast size limit for what we can deliver radiation to. It's just sort of fitting into those criteria.
So there's not a size limit, but you're looking at what's close by. So Dr. Hotca, is there a number, like how many tumors you can treat at the same time? And also, what's the distance it has to be from something else that you're not wanting to damage?
So usually when we look at these, we don't look at the number, we look more at the tumor burden. So for instance, in the liver, if there's many tumor lesions throughout the liver, then of course, radiating the entire liver would not be feasible because there's no functional liver left for the patient to have a normal function. So we look at the volume, like Dr. Chen mentioned. We know based on surgical procedures that liver function, we require about 700 cc's of normal liver function to remain. So if we're not able to accomplish that, then that will be an instance where we won't be delivering radiation. And then there's other instances where we're looking at what we're trying to accomplish. So if there's too many lesions and we obviously cannot treat all the lesions, that will be not safe for the patient to treat a large area of the patient's body because that will cause too many side effects. So we take into account what we're trying to accomplish. So often if the patient has many lesions, we may focus only on one or two of them, the ones that are either growing faster than the other ones. Oftentimes we see some lesions that do respond nicely to other treatments, but there's always some lesions that may become more resistant to that treatment. So in that scenario, we also come in with radiation to focus only on those specific lesions that are growing disproportionately from the other lesions. Then if there's a lesion that causes pain, for instance, we may focus on that one as well. So we really take all these factors into account when we decide if a patient is a candidate for radiation. There's not, unfortunately, a straightforward answer. It's really a case-by-case scenario.
It does seem like it's such an individualized approach. It's not just one nail, one hammer, one way to do it, but definitely individualized. That's very interesting. So Dr. Chen, let's shift to the bones a little bit. How does NET affect the bones? Are they on or in the bone? And does a tumor weaken the bone? I guess when we're thinking about targeting it with radiation, if you could, as a physician, explain that framework, and then we'll dive into how SBRT might be helpful with bone metastasis.
So in some cases, neuroendocrine cancers or tumors do spread to the bone. The most common places we see it is liver and bone. And when it's in the bone, most of the time, neuroendocrine tumors are growing slowly over time. And we track these tumors over time with dotatate PET and other imaging and MRIs and everything like that. And in general, when we think about bone metastases or tumors that have spread to the bone, we think of them either doing one of two things. The one is, are they eating away at the bone, kind of weakening the bone by eating away at the calcium? And what that looks like on a CT scan is there's less brightness in the bone where the brightness reflects calcium. The other way that bone metastases can behave is what's called a sclerotic lesion, or over time, actually, these lesions look brighter on the CT scan, meaning that the tumor is actually causing deposition of minerals and calcium. And so these sclerotic lesions or these denser lesions are thought to be a little bit less prone to fracture than the lytic lesions, which is the type of lesion that is eating away at the bone. And from what I've seen so far in practice, it seems like neuroendocrine tumors tend to be more on the sclerotic side. So they tend to have this white appearance and to grow slowly over time. And so perhaps to be a little bit less predisposing to fractures than other types of cancers where lytic is more predominant.
Thanks for explaining that. That is, of course, often a concern for neuroendocrine tumor patients. And Dr. Chen, we'll follow that up with just asking if SBRT then is given to the bone, does it weaken the bone?
So radiation therapy can be a risk factor for weakening bone over long periods of time. So, months to years after radiation is delivered. It's certainly not going to cause a fracture immediately or during treatment or anything like that. So it's seen as just another risk factor for fracture. And a lot of things play into that, the dose that's delivered, as well as the size of the field, and then also the underlying strength of the bone. And also, where in the bone are we delivering radiation to? Is it a weight-bearing region, which is more likely to fracture in the future? The majority of our bones are not in weight-bearing locations, so they don't particularly see a lot of load or stress, and so maybe are less likely to lead to a fracture in the future unless there's some kind of trauma. So yes, I would say, once again, it's a case-by-case situation where we usually will counsel patients and in the context of whether they have a history of osteoporosis, for example, their age, their baseline bone strength, and what our reason to treat the bone lesion with radiation, and taking all these into account, go over the risks and benefits.
Yeah, having that talk and weighing all the factors. So Dr. Hotca, what other factors do patients have to consider other than age? Is there a dose or number of treatments that might increase fracture risk? And also going back to looking at that risk assessment, should patients then have a bone density scan before SBRT?
So for bones, we really consider the location of the bone, like Dr. Chen mentioned, of course. And also we look at the baseline of the patient, if they have or the underlying bone disease, such as osteoporosis, where their bone is more weakened, things like that we take into consideration. We don't necessarily ask patients to get a bone density scan prior to radiation, especially in these scenarios where we're treating for bone pain. But often what we consider is it in a location where they may fracture? So sometimes I may send my patients to an orthopedic surgeon to be evaluated to see if they need to have any sort of intervention done first prior to delivering radiation, because God forbid, I don't want the patient to have a fracture prior to the treatment or during treatment, because radiation does work at shrinking the tumor or controlling the tumor. But once that tumor is removed, that bone remains weakened because that tumor occupied that space. I want to make sure that we have good support around that structure, around that tumor. So for instance, in the femoral neck, often that's the case that can happen. So I will often send those patients to the orthopedic surgeon. Sometimes in the spine, the patients may have pain because there's bone fracture in that area in the vertebral bodies, and they compress onto each other, and then there's bone impingement on certain areas. So I know that even if I deliver radiation, it may not be as effective because it's actually the bone that has fractured that impinges in certain areas and causes the pain. So I will often send those patients to the surgeons or to the interventional radiologist to do some sort of intervention, such as putting some cement in the bone to stabilize the bone or other procedures and remove that bone out of the way. And then I will go in radiation afterwards. So we're looking more at the structure of the bone, the integrity of the bone, and what are the risks associated with depending on where the tumor is.
Okay, so really want to make sure that the structure is solid. And Dr. Chen, I know you treat patients who have bone lesions that cause pain. So if the bone lesions are causing the pain, how soon after the treatment might someone expect to have that pain alleviated?
Yeah, we usually counsel starting about 3 weeks after radiation. There's a bit of a delay in the effects. So 3 to 4 weeks after radiation is when most patients start to have a response in terms of pain scores. And then the other thing to know is that actually right after radiation or during radiation, sometimes patients can have a pain flare. And this is usually only the case if they're already having pain at baseline in the lesion. And it's thought to be from inflammation that's generated from the radiation. The pain might get worse before it gets better, and because of some acute inflammation.
Thanks for explaining that. And that's good to know going into that the pain might flare up before it gets better and the getting better might be a little delayed. Dr. Hotca, we'll shift a little bit more to safety, and we're concerned about safety with fractures and other things. But of course, with this topic of radiation in general, patients are concerned, right, about the amount of radiation they get. So how much radiation are given with these procedures? And is there concern about radiation safety following the procedures? Like you think with PRT, right? You have to avoid people for hours or days after the treatment.
I'm very glad you're asking these questions, are really frequent questions that we get from our patients. So there are basically no procedures to take after the radiation is over because this is external radiation. So we use x-rays. So the patient does not carry radiation with them. They are not radioactive after they finish each treatment. So they can safely be around their loved ones. So there's no concerns for safety after the radiation is over. So it's really nice to be able to provide that reassurance to patients. And also in terms of how much radiation dose they receive, often patients are concerned that they're getting so many scans, just to get the diagnosis, the workup. We often also use low dose scans during treatment to focus on the area that we're treating, to make sure that we're treating the specific area that we're targeting. So patients do get a lot of scans, but when you look at that versus how much radiation they receive from the actual radiation treatment, a scan is very minimal radiation compared to the actual radiation dose that they're receiving from this type of treatment. And often we measure radiation that we use here in gray. So it's many, many grays comparing to much less for the x-ray. So usually an x-ray is considered to be the same amount of radiation exposure as you would take a flight in a plane. So that's very minimal compared to the radiation dose that we often deliver to patients. But of course, we are more focused with the radiation that we give.
Yeah, that is helpful. And I'm glad you brought up the scans. I know patients are often concerned about the number of scans they receive over their lifetime with CT and PET scans. And Dr. Chen, is there a lifetime amount of radiation one can get? And considering all those surveillance scans, then do you count that in when you're treating someone for SBRT?
Yeah, good question. And I do get that question from patients from time to time. Is there like a lifetime limit to how much radiation I can receive? And I think in radiation oncology, we operate by this principle called ALARA, or as low as reasonably achievable, meaning that we don't have data on is there truly a lifetime limit on radiation in humans, because we can't do that experiment. We don't have that data historically to be able to say for sure. And so we just operate on a theoretical basis that less radiation is better. And so over the long term, neuroendocrine cancer patients can live for a very long time. I think it makes a lot of sense to try to minimize CT scans as much as possible, perhaps do MRI if possible. You see a lot of our patients getting serial MRI of the liver and then maybe PET dotatate pretty infrequently, once a year, something like that. But as far as whether that impacts radiation treatments and our recommendations, I would say no, we don't take into account prior scans and the dose accumulated from scans, because like Dr. Hotca mentioned, the doses from a CT scan are an order of magnitude lower than what we would deliver for radiation. But of course, when we deliver external beam radiation, we're of course very focused in a very small area because we can't do these doses of radiation to larger areas safely. But then if you look at the dose of radiation we're delivering to this high dose area and compare it to even 100 CT scans or 150 CT scans, it's an order of magnitude larger. So we don't take into account prior scans. And then as to the question of, is there a lifetime maximum of radiation we can deliver therapeutically? Again, it's case by case. I think Dr. Hotca mentioned before, we're always very careful when we're in the re-irradiation setting, meaning a repeat external beam treatment. But it's certainly not a hard and fast no. We can do it in certain cases. We just have to be careful and make sure that the indication and the risks and benefits are all discussed with the patient.
Thanks for explaining that. That is common. And how often can these procedures be repeated in the same person?
So for external beam radiation, I would say that it has to do with how much overlap there is between the first radiation and the second radiation. If it's in the exact same spot, then it's of course riskier. And again, there's no hard and fast rules saying we can't do more than 2 times, for example, but after 2 times, become even more cautious and the risks go up even more. So I think we see from time to time re-irradiation for the second time. Very occasionally, we'll discuss with patients a third time. And then beyond that, I think I've very rarely heard or seen. But if it's in a totally different location, no overlap or minimal overlap with the previous radiation, then we can treat it as a new radiation dosing or treatment. And so we don't have to take into account the prior radiation elsewhere.
Okay, that's helpful to understand. It depends on the radiation, the same part of the body or organ. Dr. Hotca, you mentioned before that you're attentive, you're thoughtful, and you're planning about what's next to the tumor that might cause damage to. So what kind of damage might it cause to other tissues or organs? And also, is there a concern for any secondary cancers?
Great question. And I get this question often by my patients. What are the side effects? So usually it really depends on the tumor location. So it's all based on the location. So if there's nearby, let's say bowel, it can cause irritation to the bowel, and that translates into it may be nausea, maybe ulcers, maybe diarrhea, anything that leads to irritation to the bowel, basically. And there's ways to prevent that by reducing the dose to the nearby organs. Also, sometimes we use medications such as anti-nausea medications. If I know I'm treating pancreatic lesions, I often prescribe that to my patients. If I believe that they may be at risk of developing any ulcers, I do prescribe them acids as well during treatment to kind of minimize the acidity in that area as well in the bowel. So there are ways that we can be proactive about it. In terms of other organs, let's say we're close to the kidneys, we are worried about that, especially if the kidneys are not functioning that well. Then when we do design our plan for radiation, we limit specific radiation dose to that area. Sometimes we may have to sacrifice coverage to the tumor in order to preserve function to a certain organ. So we're able to modulate that with the techniques that we have nowadays to limit exactly how much dose we give to those organs that we worry about. So we have kidney, bowel, those are the major ones. Of course, lungs as well. If we're treating a tumor in the lung, sometimes radiation can cause inflammation in the lung. And often that side effect develops after the radiation is over. So we do follow these patients closely. And then if they do develop inflammation in the lungs, that translates to similar to a pneumonia, having cough, a little shortness of breath. And we often take a scan and we do see the changes in the lung, and that it's usually treatable with steroids. So it's not permanent damage. So it really depends on the nearby organs. If we are close to the esophagus, then the patient may have mucositis in that area. So it means they may have a feeling of pain when they eat with food. When they eat, they're not able to swallow easily because it is inflamed and painful. So at that time, we often prescribe patients something to either take by mouth to numb the area so they can eat a little bit, or sometimes they just have to change what type of food they eat, switch to a more soft diet temporarily during the treatment and a few weeks after the treatment is over. So it's really dependent on the location of the organ that we're treating.
Thank you for giving us some examples in bigger picture. What about secondary cancers? How common is that?
So that is always something that I advise my patients, even though often they're like, oh, we shouldn't worry about it. It's such a long time from now. But actually, there is a risk. That risk is not well defined. We've been using older studies in pediatric patients that receive radiation therapy. We also use more archaic techniques of radiation where patients had more exposure to the entire body. And so nowadays, we're more precise with radiation. So the exact number, we don't know exactly what it is, but we often code patients in around 1 to maybe 5%, 10 to 20 years from now with developing secondary malignancies in the location where they receive radiation. And, if they were, God forbid, to develop a secondary malignancy, the way it's treated, it's really just treated similar to a primary malignancy. And that can involve surgery, chemotherapy, even radiation. Sometimes we use as well. So it really depends on the location of where they would develop that secondary malignancy. And I forgot to mention earlier when you asked the question about what are the instances where we do not want to give radiation, some patients may have some sort of genetic syndromes that predispose them of being more sensitive to radiation in general, like Li-Fraumeni syndrome is one example, where they just predispose to developing more cancers in general and be very sensitive to radiation as well. So we know that these patients can have a risk of up to even 50% of developing a secondary malignancy. So those are also instances where we more careful think about if we should even deliver radiation for these patients because of that higher risk of secondary malignancy.
Yeah. So for those type of people that are predisposed, how do you know if you're one of them?
So luckily nowadays we do more and more genetic testing for patients. So we often find that way, but of course sometimes we don't. And then we just notice that after the radiation is delivered, some patients may all of a sudden develop a secondary malignancy out of proportion to a general person that would receive radiation. So that's when we start investigating. And so unfortunately about these patients, we do find afterwards. But nowadays, since we are using more and more genetic tools and testing, we often are aware of it in advance.
Thanks for clarifying. And is there a risk with fertility as well?
Fertility, definitely. So for patients that are of reproductive age, we always counsel about potential risks for fertility. And usually only when the radiation is in a general area where the reproductive organs are. So the ovaries and the testicles are very sensitive to radiation. Just a few gray of radiation can actually cause significant impact to fertility. So the best way that we can help preserve fertility is by avoiding radiation to those structures as much as possible. So the ALARA principle. So by using imaging, by using all the tools at our disposal to make sure the dose going to the ovaries and the testicles are very, very low, that's the best way that we can preserve fertility. And also we can help mitigate that risk by keeping the radiation field as small as possible.
Thanks for explaining that. I know, Dr. Chen, you've been in these tumor boards where they talk about the other types of approaches, PRT, radioembolization, interventional radiologists might do. How do these therapy, the external beam radiation therapy, compare to PRT or radioembolization in terms of safety?
In terms of safety, I think it's hard to say in terms of a head-to-head comparison. Nobody's really done a head-to-head trial where you randomize people to one or the other to be able to say for sure the safety and efficacy outcomes. But as we talked about in many of these questions, the particular right treatment for a particular case can differ. And I think all of these treatments can be very safe in certain situations and maybe less safe in others, and also can be very effective in some situations and maybe less effective in others. But in terms of a comparison to other focal therapies such as ablation or embolization, SBRT is probably at least comparably safe and comparably efficacious as a whole. But case by case, there may be one or another treatment that makes a little bit more sense.
And Dr. Hotca, if someone has had PRT or radioembolization, can they also receive radiation therapy to the liver or bones?
Absolutely, because we are focused on a specific area, so there's no contraindication with regards to prior other types of radiation treatments, such as PRT. So patients can safely receive radiation treatment.
And Dr. Chen, what about other agents like captam, alkylating agents? And if they've had all of these, I guess there's a concern like, does toxicity increase over time and have a combination put you at risk for secondary cancers?
Well, with respect to the CAPTEM and other systemic agents, we usually just try not to overlap directly with radiation in terms of time. So we usually hold chemotherapy for at least a week before radiation and maybe about a week after, sometimes shorter, sometimes longer, depending on the agent and the situation. And that's just because if you give radiation at the same time as capecitabine or temozolomide is in your system and in the blood, there can be a synergistic effect where the radiation is kind of boosted by having these agents on board. So we just try to avoid having them directly overlap. But if you had CAPTEM in the past or other chemos or biologic agents, there's not particular concern in my mind to having SBRT in the future. We do take into account the global liver function, how's this patient's liver doing in general, but that's a harder thing to nail down and it is really case by case.
Is there like a lifetime or cumulative effect overall with having PRT, radioembolization, alkylating agents, and then SBRT? Does that increase your chance for secondary cancers?
So for secondary cancer risk question is a little harder to answer, but the cumulative effect usually comes into play for the liver. In very rare situations where patients have had many, many rounds of PRT and, chemo and then SBRT, then there starts to be more caution with respect to, how is the liver tolerating all these treatments? But because these are rare situations and PRT has not been around for so long, and we don't have a ton of data, we can't rely on data sets or studies, and then it really comes down to case-by-case consideration of everything. For the secondary malignancy question, with PRT, there's a very low risk of myelodysplastic syndrome, MDS, a blood disorder. There's been some suggestion that prior radiation can also impact that risk, but once again, it probably has to do with how much of your bone marrow has seen radiation in the past. So if you've had previous SBRT to a small field, probably very minimal impact on your risk of blood cancers in the future. But if you're a rare patient that as a child maybe had a large field radiation for lymphoma, or even some patients will have total body radiation for stem cell transplant in some situations, those are very rare scenarios, but those might be situations where your prior external beam radiation might impact your risk of secondary hematologic or blood cancers if you do have PRRT.
Thank you, Dr. Chen. Dr. Hotca, is there a sequence to it? If someone's going to get PRT and SBRT or radioembolization SBRT, is there a way you would sequence this?
It's really hard to answer because it's all specific to the patient, and that's where we lean towards presenting those cases to tumor board in general, so we can have a multidisciplinary discussion with all the specialties. But we really look at the patient and what's the urgency, right? What we are trying to accomplish. So if, let's say, the patient has a painful bone lesion or a lesion that is growing very fast in the liver, then we may start with SBRT because it's a very short treatment. It can be delivered in 5 days total, very quickly. So we may start with that just to provide some quick local control to that area and then moving on to other therapies. So it really depends what we are trying to achieve. And sometimes if there's no urgency to deliver SBRT, if we think that growing slowly, but patient has the larger tumor burden throughout the body, then we may focus more on systemic treatment or PRT that may have an impact on that first, and then come in with a more local treatment like radiation to focus on that specific spot.
That's helpful. Thinking of the goal of therapy, the goal of the treatments. And Dr. Chen, let's shift to what SBRT is like for the patients. Dr. Hotca just said is 5 days or 5 treatments. What's the planning and preparation process, and how do you determine how many treatments and what dose to give?
So logistically speaking, I can walk through the process. So basically, the very first step after you meet with the radiation oncologist and decide on the plan of action is what's called a planning CT or a planning scan. Sometimes it's also called a CT simulation because we're simulating as if the patient were going to get radiation, but instead of actually getting radiation, you're just getting a scan, a CT scan. And that scan is actually not a diagnostic CT scan. Sometimes it can be confusing. So it's not actually read by a radiologist. It's solely for the purpose of us to plan radiation. And it usually takes place in the same department, location as the radiation oncologist, and the treatments will happen. That CT scan can sometimes be done with IV contrast, without. It depends on the situation. There might be other things that happen during the simulation. Like, for example, we create this custom beanbag thing that the patient can lie in that helps to cradle the body and keep the body in the same position every day. So custom immobilization device. We've previously mentioned this idea of breath hold. So we have these devices where we can help the patient track their own breathing. So sometimes that involves a little mouthpiece that you breathe through. You actually wear a set of goggles where you can see your breathing trace, and then that helps the patient hold their breath in the exact same range every time. So that'll be set up during the CT as well. And then sometimes we even do an MRI in addition to the CT, also for planning purposes. And it's not done everywhere, but some places do have MRI machines that can do MRI simulation, which is what we do here often for liver tumors, because we can visualize tumors a little bit better on the MRI in the liver. And then for radiation itself, usually it takes about a week or 2 weeks to actually create a radiation plan. And there's a whole bunch of people involved in that. In addition to the radiation oncologists, there's physicists and dosimetrists in the background that are sort of working on crafting this radiation plan and doing all the quality assurance checks. And that's why it takes a week or 2. Then when the radiation starts, you can expect to be at the radiation center. Usually it's either daily or every other day, depending on the situation. And then when you come each day, you'll probably spend a half hour or an hour total in the radiation departments. And a lot of that time is, your typical checking in, waiting around for the machines. And then once you're in the treatment room, usually you'll be on the machine for 15 minutes, 20 minutes, something like that. And the experience for the patient is very similar to getting a scan, usually lying on your back in that custom beanbag that I mentioned. And then there's basically a big machine that looks like a scanner, and that's the radiation machine. And then it moves around you in a circle. Usually, that's how the machines will work. They move around you in an arc. And as it moves around you, it's delivering the x-rays from the outside in. And similar to as if you're getting a CT scan, you don't feel anything, you don't see anything or really notice anything. It's a painless procedure and usually pretty quick as well. And as to the question of how many times and how many fractions and how do we determine that, As we've mentioned before, sometimes the reasons that we go to longer fractionations, meaning more days of radiation, is if we, for example, are worried about a structure nearby and we want to be more safe, we can deliver lower doses of radiation on a daily basis for a long period of time. So most commonly, maybe 10 or 15 total sessions, Monday through Friday. So that would be about 2 to 3 weeks. And then in some cases, and for other kinds of cancers, we actually treat even as long as 5 to 6 weeks daily, Monday through Friday. But for neuroendocrine tumors, I think that's less often the case. I would recommend something like that.
Thank you for that really helpful overview. And just to follow up, Dr. Hotca, patients always are concerned about what they experience during and after the procedure. What if they're claustrophobic and they take something typically for their scans to relax them? Should they take something? Is claustrophobia a problem? What other side effects might there be, and how much time should they plan to take off of work?
Yeah, those are very important questions. So basically, the radiation machines that we use, they not enclosed. It's not like an MRI machine. So it's an open space, typically a large room where the patient is alone in the room, laying flat, similar to a CT scan table with that beanbag that Dr. Chen mentioned around them. Sometimes if we treat an area around the neck or the head, we do place a plastic mask on the patient's head, kind of position the head to make it stable during treatment. And that may cause a bit of claustrophobia in some patients, but that mask is made of plastic and has holes through it so the patient can see and breathe through it. And sometimes we can create bigger holes around the mouth and the eyes so the patient can be a little bit more comfortable. So that would be the instance where I would anticipate maybe some sort of claustrophobia, anxiety. And if that's the case, we do sometimes pre-medicate them a little bit. And so that would be the only instance that I would anticipate some of that issue, but overall, it's actually a very large room. We can see the patient, we can hear the patient during the treatment. I always tell that to the patients. We can even play music during the treatment for the patient, so they can choose the music that they want, so they can be a little bit more relaxed during the treatment. And typically those spend about anything between 15 to 30 minutes or a little bit longer if we're using one of those breathing techniques for patients on the table. So during treatment, they really don't feel anything because it's X-ray, so you can't see. But that doesn't mean, obviously, that there won't be side effects afterwards, which leads me to your other questions about side effects. How would they feel? Especially for short course of radiation treatment like SBRT, I often tell my patients that the side effects will start happening after the entire radiation treatment is over because radiation takes time to work on the tumor cells. So we don't typically see after one radiation treatment or two radiation treatments any side effects. Often they do start coming in much later. But much later, I mean about a week or two afterwards. So in terms of the side effects, the most common side effect is fatigue. That often happens after the radiation is over, and it can last actually for a few weeks after the radiation is over. But the fatigue is mild. Often patients tell me that they need to take an extra nap during the day, go to bed a little earlier, that kind of fatigue. Other common side effects that we see is a little bit of skin irritation, especially if the tumor is closer to the surface of the skin. That's when we start noticing some rash, a little bit of redness, similar to a sunburn. And that's when we prescribe creams to patients to apply. But nowadays, many patients don't even experience that skin irritation, but we still give them the creams just to have them. So the patients always, doctor, do I still need to apply the cream? If I don't have any irritations, I often tell them they don't have to if they don't have that irritation. So those are the most common side effects. The side effects depend on the location that we are treating. Like I mentioned, if we're treating close to the bowel, pancreas, liver, those things can lead to some nausea, and that can last a few weeks after the radiation is over as well because of that delay effect. But typically, our patients are able to continue doing their daily routines. Most of our patients continue, if they work prior to the radiation treatment, they will be able to continue working during the radiation treatment and after. Just a little bit of that fatigue that adds up to it, but it really depends on how functional they were before treatment. And they typically remain similar to that for this type of treatment, especially for SBRT, because we're so focused in terms of the treatment that we deliver, so we don't cause that many side effects to impair the patient. And they'll often ask us if they have to come with somebody for treatments, and depending on their functional status before to treatment, if they don't require any assistance prior to treatment, I don't anticipate them requiring during treatment either.
So they can drive themselves to and from the treatments if needed.
Correct.
This sounds very promising. So, Dr. Chen, how effective is SBRT in managing symptoms and also in controlling or destroying the tumor?
I would say that SBRT can be very effective for both of these things, of course, case by case. But there are some small studies showing that local control, meaning that where the radiation is applied, the tumor stops growing or even shrinks over a prolonged period of time, can be very high. upwards of 90% or something like that. And in terms of how do we know if the treatment works, how do we track the efficacy of treatments? We've mentioned before that radiation is kind of a slow-acting treatment. So the X-rays come in and have damaged the tumor cells' DNA. It takes time for the full effects to occur and for tumor cells to either stop growing or to shrink away and die. And so usually how we track patients is the same way that they've been tracked throughout their whole course, which is with imaging. Usually patients will just resume their typical schedule of scans, whether it's every 3 months, 6 months, or even 6 to 12 months. And over time, we would see that in the lesion that's been treated stops growing, first of all, or even can shrink slowly over time. Usually it will take at least weeks to months to even see any measurable shrinkage, but it can even happen 6 months down the line or 9 or 12 months or even longer.
Thanks for explaining that. And we'll end with this last question. I mean, this sounds like an exciting field. It shows a lot of promise. It's well tolerated. It's minimally invasive. It's not invasive. And there's a lot of thoughtful planning with it that can be individualized. So, Dr. Hotca, let's start with you. What do you see as the future of radiation therapy in neuroendocrine cancer treatment?
Like you mentioned, it's a really great tool for our patients, especially for local control. But I think looking ahead, I see radiation therapy evolving with advances, more technical advances actually, like adaptive radiation, which we started doing some research in that area as a field using different types of machines to deliver radiation, such as machines that have an integrated MRI in the actual radiation delivery treatment machine. And that allows you to visualize that at the organs that you treat, and then especially the nearby organs, and kind of adapt the radiation with the movement of the organ. So that is a fascinating field that, I'm very excited for it and see the future of it. So I do think the advance is really into adaptive radiation and also using other ways, other imaging tools or biomarkers to look at tumor response during treatment. So if the tumor responds nicely, maybe we decrease the dose of radiation, or maybe some tumors that don't respond that well to radiation, maybe we increase the dose. So we still have a lot of work to do in that area. Even though now we provide personalized radiation treatments to every patient, I think we can do even a better job adapting to each specific tumor itself on how they respond to treatments. That's where I see the most advances coming for our field.
Yeah, refining and customizing the treatment so it's even better and more effective.
Mm-hmm.
Thank you. Dr. Chen, what about you?
I would say that as the field advances as a whole, as neuroendocrine cancer patients are living longer and longer, I think there may become more roles for local directed therapies, not just radiation, but surgery and embolization and everything else. And so I think there's a lot of research to be done and a lot of work to be done in trying to understand, for example, you asked about the sequence, what's the optimal sequencing of all these different treatments, or what's the optimal combination of treatments? Are there situations where if we do radioembolization or another embolization or chemoembolization in addition to radiation or in addition to another treatment, could that boost the treatment's efficacy? I think there's a lot of open questions as to sequence combination in the future, in addition to everything that Dr. Hotca said.
So much more to learn and grow. Well, thank you both for all your work in this field and your continued passion. And we look forward to hearing and seeing more advances, probably led by the two of you. So thank you so much. And on behalf of the neuroendocrine cancer community, thank you for all you do.
Thank you so much.
Thanks for having us.
Thank you.
Thanks for listening to the LACNETS podcast. Go to our website, lacnets.org/podcast for episode transcripts and resources. We want to thank our podcast supporters, Novartis, Ipsen, Crinetics, Exelixis, ITM, Curium, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to www.lacnets.org. LACNETS depends on donations to bring you programs such as this podcast. Please consider making a donation at lacnets.org/donate.